Good afternoon. How is everyone? Doing well on this rainy Orlando day. My name is Rob MacLaren. I'm a professor at the University of Colorado, and I always say a pseudo-pharmacist in the medical ICU. We have three of us speaking today. I'll be a moderator, your tour guide, and your second speaker. So if you're not aware, we have some stress ulcer prophylaxis guidelines that came out in July, and so we'll be discussing some of the recommendations from those guidelines. So our first speaker was instrumental in getting the guidelines finished. She was our methodologist. She comes to us all the way from my home city of Hamilton, Ontario, so there's a special place in my heart for her. Dr. Joanna Dionne, and she is a gastroenterologist and a critical care physician. She's also an assistant professor in the Division of Gastroenterology and Critical Care Medicine at McMaster University. So please welcome Joanna.
Thank you, everyone. Good afternoon. I want to thank the Society for the opportunity to present with you today. And guidelines take a lot of man hours and a lot of people and a lot of meetings, and it's my pleasure to represent an incredible, diverse committee, including Dr. MacLaren and Dr. Barletta, my co-speakers. In terms of disclosure, mostly intellectual, I've received peer review funding from CIHR, the Canadian Association of Gastroenterology, Physician Services Incorporated, and Canadian Association of Transplantation, and I've been a guideline methodologist representing the guide group for the Society of Critical Care Medicine, European Society of Critical Care Medicine, Canadian Blood Services, and CASTLE in Canada. So I'm going to review grade methodology, and we're also going to discuss who should have SUP, an overview of modern risk factors for stress ulcer-related bleeding, and provide a current update of evidence and future research directions that we identified at the end of our guideline. So grade methodology, grade was developed to help prevent the chaos of guideline meetings. Before grade was developed by Gord Guide and colleagues, meetings would often consist of a bunch of people in a room, and the loudest, most opinionated person won. It was like a hockey game. So in order to develop a streamlined, clear process, grade was developed. So this is what happens with grade. It sounds very magical when we talk about it, but it's actually quite simplistic in what we do. So we develop PICO questions that have a very streamlined population, intervention, comparison. And then we work with the panel to determine outcomes of interest to patients, providers, and policymakers. That then goes through a Delphi process rating the importance of the outcomes, with 7 to 9 being critical, 4 to 6 being important, and under 3 not important. Once that's determined, the guideline methodologists go away, and we do magical things called systematic reviews for each PICO question, and then we create an evidence profile. And we rate the certainty or quality of evidence. So randomized control trials start as high certainty of evidence, and then work their way down in terms of certainty, determining by risk of bias, inconsistency in the studies, imprecision of the results, as well as publication bias. Observational studies start at low certainty of evidence and work their way up in terms of opposing biases, confounding factors, a dose response, or a large effect size. So a good example of observational studies that actually resulted in high certainty of evidence is smoking cessation and lung cancer. Once we have that, we go to the panel and we develop a evidence to decision framework, and that we look at certain factors. We look at the balance between the harms and benefits of the intervention, the overall certainty of evidence, as well as important values and preferences difference between clinicians, patients, and policymakers, the resources required to actually do the intervention. Is it cheap and cheerful, or is it going to cost $300,000? Equity, always an important factor. Would it be acceptable to patients to have this intervention and providers to administer the intervention? And is it feasible? We then create these evidence to decision frameworks for each recommendation we have that creates a record of the meetings and transparency of how we came up with recommendations. With the panel, we then create a recommendation moving on a continuum between strong, for or against the intervention, or weak or conditional recommendation. And with grade methodology, we use the terms we recommend for strong, high certainty recommendations, and we suggest for conditional recommendations. and that's how we determine it. So I want to talk a little bit about risk factors for gastrointestinal bleeding in the modern era. When Cook and colleagues did the original study in 1994, critical care looked very different. This predates ARDSNet and lung protective ventilation, predates the importance of enteral nutrition on mortality benefit. It predates resuscitative trials that looked at volume resuscitation. And when we started the guideline, we sat as a panel and said, we really need to look at what modern risk factors actually exist and increase a patient's risk of gastrointestinal bleeding. So we did a systematic review and meta-analysis of predictors of gastrointestinal bleeding. Back in 2019, seems like a very long time ago. You know, there was this little virus that was floating around shortly after, and we all went through this time warp. So it seems like it was a year ago, but it was actually quite a long time ago. And so the purpose of this review really was to identify predictors of GI bleeding in adult ICU patients. And we conducted a systematic review meta-analysis of both cohort studies and trials, and included 8 studies of over 100,000 patients. And 4 out of 8 studies, including 74,000 patients, assessed potential risk factors. And we were able to meta-analyze 12 potential risk factors. So the associated increased risk of GI bleeding was seen in patients who have acute kidney injury, as well as those with male gender. But when we further refined it and looked at low risk of bias studies, we found that coagulopathy, shock, and chronic liver disease actually increase your risk of GI bleeding. But interestingly, the effect of mechanical ventilation was quite uncertain in the modern era of critical care. So that raises the question, who needs SUP? Is it SUP for everyone or SUP for some? So Grenholm and colleagues actually took the study a step further and looked at these risk factors in the context of the SUP ICU trial. And this was a post hoc analysis. And they found that mechanical ventilation may no longer be an inherent risk factor for stress ulcer-related bleeding in modern critical care. But people who were at risk were those with coagulopathy, shock, and chronic liver disease. This resulted when we made the recommendation that we suggest that critically ill adults who have coagulopathy, shock, chronic liver disease be considered for stress ulcer prophylaxis. And we issued a conditional recommendation. We suggest clinicians provide SUP to prevent clinically important upper GI bleeding in critically ill adults with risk factors. And you can use either PPIs or H2RAs. So where is the evidence in the post-pandemic and intra-pandemic era? So as I mentioned, Cook and colleagues did some of the seminal work back in 1994. And critical care has changed. Our patients have changed. We have changed. So what should we do now with stress ulcer prophylaxis? So we need to revise. Sorry, bad joke, but we need to revise what we're doing. So the revised trial was published in the New England Journal of Medicine in 2024 and found that, not surprisingly, PPIs decrease the risk of clinically important bleeding, as well as patient-important bleeding, which was a new outcome, but did not affect mortality between the two groups, which was also seen in other studies, modern studies. And there was no difference between ventilator-associated pneumonias and C. difficile. When I was doing my doctoral work, half of my committee were gastroenterologists, half were intensivists, and they could never agree on C. diff and PPI effect. So it was great to see this come out, no more fighting. So then we took the trial and looked at the combined evidence, and this was published in New England Journal of Medicine Evidence. And once again, this incorporated the revised trial and showed that, yes, PPIs do decrease the risk of clinically important bleeding, as well as avert upper GI bleeding, but no difference in mortality. However, I will highlight that in the modern studies, SUP, ICU, as well as REVISE and PEPTIC, there was a signal of increased mortality in the more severely critically ill patients, which is also seen in this meta-analysis. There was no difference in pneumonia or C. difficile, as well as mechanical ventilation, duration of ICU stay, and duration of hospital stay. So we've talked about who's at risk for stress ulcer-related bleeding, where we're sitting in the modern era, to put our current guidelines into context. But what are the costs and resources to actually administer this intervention? So the Danish group actually looked at this and did a post hoc economic analysis of the SUP ICU study. And they actually looked at health economic analyses at 1 year post ICU, specifically in the Danish cohort because they actually have access to all the administrative data. And interesting enough, sure, they showed that PPIs do reduce the risk of clinically important bleeding and upper GI bleeding, but there was no improved ICU or 1 year outcomes or reduced healthcare costs with the rarity of GI bleeding and providing stress ulcer prophylaxis to all, which also highlights the precision prescribing that'll be discussed further by my colleagues. So what's next? So after we completed the guideline, we came up a list of research priorities. Guidelines help to direct care, but they also help direct future research. So when it comes to risk factors for GI bleeding, we need further studies that look at the persistent risk over time, and if once you resolve the risk factor, do they still need stress ulcer prophylaxis, as well as the development of scoring tools to stratify risk and impact of risk of bleeding with multiple risk factors. Does it compound your risk, or is your risk just higher with one, if not more? We also need further studies to look at the effect of EN on GI bleeding risk, RCT evidence on EN alone compared to SUP added, and the effect of EN mode, type, and dose, as well as timing. And further studies really need to explore this signal of increased mortality in the more severely critically ill patients. And being mindful of the interventions that we prescribe to our patients, when should we stop them, is just equally important. So further studies should look at cessation of SUP, SUP administration, looking at oral routes versus the IV route, which was studied in REVISE, and those populations at increased risk, so the neurocritical care and the burn patients. So in conclusion, 7 years of work comes down to 3 points. It's amazing, actually. So you apply risk factors and predictors of GI bleeding to guide who should receive stress ulcer prophylaxis, use of agents, so PPI versus H2RAs, and further studies should focus on refined fine-tuning of prescribing practices. And as I said, this took a community to do, and I'm thankful to the panel, the society, for supporting this work through quite tumultuous times with the pandemic. So merci, thank you.
We'll hold questions till the end. Hopefully we'll have some time. All right, just making sure it all shows up okay. Okay, so as mentioned, my name is Rob MacLaren. I'm a professor at the University of Colorado, and I'm going to dive a little more into which agent we should choose, and I think Joe's already done a nice job of saying that either one is probably okay, and I'm going to dive into the literature a little bit more, if that's okay with everybody. I don't have any conflicts. I was co-chair of the SCCM ASHP Guideline on stress ulcer prophylaxis. Our objectives today is to go through some of the agents, specifically H2 blockers, PPIs. We'll go through some of the recommendations. I always like to bounce off our recommendations with other recommendations so you know what is out there. And ultimately, what I'm going to say to you now is go back to your institution and see what you're doing. None of us ever up here thought we'd be talking about stress ulcer prophylaxis. I've been practicing for 30 years, and I just assumed it was ingrained. We didn't have to worry about it. Yet I will tell you, and I'll show you our data that says we're doing a lousy job at the University of Colorado. Ultimately, what we should be doing is making sure we're preventing bleeding. I'm not going to worry about mortality because there's not a whole lot of data about bleeding causing mortality, but maybe there might be some differences in agents. We want to minimize adverse events, and I'm talking today about targeting the right drug, so the right stress ulcer prophylaxis, I think the right patients is what Joe just talked about, and Dr. Barletta later will talk about the right duration. So those are probably more important than the right drug. All right, by show of hands, here you have a patient. I've just made him Jack, 67-year-old male. You can see septic shock. He's on 2 pressors. He's on a ventilator. His lactate's high. He's got a little bit of an AKI. Who would give stress ulcer prophylaxis? Everybody. Now, the question becomes, who would give A, a PPI? Who would give B, an H2RA? Sucralfate? Any sucralfate fans still? No one. How about just enteral nutrition? And how about nothing is needed? All right, so we got a little mix. So I don't want to go through a huge timeline, but I will just for sake of completion. If you all remember, and I remember this, running around with litmus paper in my lab coat, and I would get a little bit of gastric aspirate, and I would look at what color it changed, and if it wasn't the right color, I would dose adjust to make sure the gastric pH was like at least 4, right? And then H2 blockers came out, and we did the same thing. We used to run infusions, and we used to add on antacids, and the nurses were giving these things every 30 minutes. Well, then sucralfate came out, and we didn't have to worry about checking gastric pH anymore. There were lots of studies at that time that compared sucralfate with H2 blockers, and when you did a meta-analysis, what you saw was really no difference in bleeding, but maybe it's a trend towards harm with H2 blockers, primarily because maybe we're increasing gastric pH, causing microbial growth, aspiration, et cetera, et cetera. Well, to Deb Cook's credit, when she saw this, she ended up doing a randomized study of ranitidine not dose-adjusted for gastric pH versus sucralfate, and guess what? There was a statistically significant reduction in clinically important bleeding with ranitidine. And so that's really the study that made H2RAs at the time the gold standard. Somewhere along the way, PPIs were marketed, and they did a great job marketing, I will say. There were not many studies, but a lot of small studies. And if you start doing meta-analysis in sort of the mid 2005, 2010-ish range, you start seeing that PPIs reduce clinically important bleeding, no difference in any other outcome. So we all changed to PPIs, right? All right. Now, when we went back and surveyed all of you, SCCM prescribers, you told me that 60% of you would prefer H2 blockers. Now, when Dr. Barletta and others actually looked at what we were doing, we were giving PPIs. So I always say this is a classic example of we don't do what we say we're doing. All right, so go back and look at what you're doing. All right, now, lots of guidelines are confusing. All you have to do is look at the Surviving Sepsis campaign, and despite the fact that the data didn't change a whole lot, their recommendations changed from giving H2RAs and PPIs are preferred, then either, and then just give stress ulcer prophylaxis, right? Makes it simple. If you go over to Europe, there's some countries that don't recommend stress ulcer prophylaxis, and that's for research purposes. And some of you may be aware, BMJ in 2020 published sort of the rapid guidelines and said, you know what, PPIs probably are better, but you really don't have to give stress ulcer prophylaxis unless your rate of bleeding is greater than 4%. Who knows what their rate of bleeding is in their institution? Do you all? No one, right? I know my rate because I've looked at it, but I will tell you it's not 4%. And this is what they sort of come up with their risk factor analysis, right? And I don't know how they came up with these numbers. I don't know how somebody had 2% or 4% for these risks, right? So if you just have sepsis, you have a risk of about 2 to 4%. If you're on a ventilator without enteral nutrition, it's 8 to 10%. It seems that's a little high to me, but the cutoff there is at 4%. All right. So what did we come up with? And Dr. Dionne already mentioned this, but we said either PPIs or H2RAs are fine. PPIs probably reduce clinically important bleeding compared to H2RAs, but, and I'm going to show you some of this data, there's an association with increased mortality, and start asking why, and do I care about that mortality, et cetera, et cetera. So if I go and look at cohort studies, these are not randomized studies. These are cohort studies, large database analysis. What you see, surprisingly, is H2RAs are associated with reduced mortality compared to PPIs and a reduction in clinically important bleeding. That would make sense. Mortality's less, bleeding's less. It all goes hand in hand. If you actually look at some of the studies, and this is ours that we did propensity matching, and you see that the H2RAs are associated with less bleeding, less pneumonia, less C. diff, less mortality, and so all that goes hand in hand. It sounds great, right? The problem is when you start doing meta-analysis of randomized studies, you see the opposite. You see PPIs reduce clinically important bleeding, but might be associated with increased mortality. And so this was the meta-analysis that we did for our guideline. I just want to harp on a couple studies. I think it's always important to realize what kind of data goes into this. I mean, we all like meta-analysis. They do a great job of summarizing. But here's a couple studies that, to some degree, drive some of the meta-analysis, at least the older ones. The Conrad study was a study looking at cimetidine by infusion versus an omeprazole suspension, and that omeprazole suspension was one that Dr. Conrad had some proprietary input into. Their definition of clinically significant bleeding was not what we classically term hemodynamic compromise or transfusion, but rather gastric lavage that wasn't clearing. And you can see that the rates of bleeding were about the same. The Levy study, one that gets quoted quite a bit, 67 studies looking at ranitidine infusion versus a simplified omeprazole suspension. They did have a real definition for clinically important bleeding, but look how high it is in the ranitidine group, 31%. Why? Because those patients had a lot more risk factors. Majority of the patients in the omeprazole group were not intubated. The majority of the group in the ranitidine group was intubated. So you always have to look a little bit at the studies that go into meta-analysis a little bit. This is a study that sort of got our attention a little bit. This is a large cluster randomized study done in England or the UK, and it's 50 ICUs. So rather than randomizing the patient, they're randomizing the ICUs. For 6 months, you get PPIs. For 6 months, you get H2RAs or vice versa. Very pragmatic. Obviously, there's some issues there in terms of crossover, et cetera, but see, clinically important bleeding was less with PPIs. Notice the rate, 1.8%, 1.3%, so a lot less than the 4% BMJ would say you need to give stress ulcer prophylaxis. There was a trend towards increased mortality with PPIs. We don't know why. All right, if you look at number needed to treat or number needed to harm, there's fewer needed for mortality than for bleeding. What's really striking is if you start doing subgroup analyses and looking at those who are most severely ill, that's where you see the difference, all right? So you have an increased mortality with those who got PPIs. Who are you going to use stress ulcer prophylaxis in? You're most severely ill, right? So there's a little bit of a concern there. These are placebo-controlled studies, and Dr. Dionne already mentioned this one. This is a SUP-ICU study looking at pantoprazole versus placebo. You'll see the same type of study on the next slide, or the 2 slides from now. Notice there's no difference in mortality, but pantoprazole reduced clinically important bleeding. 4.2% in the placebo group, right around that 4% of needing stress ulcer prophylaxis. Now, it is kind of concerning, again, in the subgroup of SAPS 2 score greater than 53, the patients who were sickest had higher mortality with PPI, or associated mortality with PPI, compared to placebo, despite the fact that bleeding was less in that group. Now, the revised study, I guess I have the same joke, time to revise recommendation. Very similar in terms of the SUP-ICU, 40 milligrams of pantoprazole versus placebo. Notice no difference in 90-day mortality, but a difference in clinically important bleeding, right? When you start mixing these studies, and Dr. Dionne already showed you this slide, is in those patients who are more severely ill, when you look at placebo versus PPI, there is an association with increased mortality. And those who are less severely ill, there seems to be the opposite, where maybe mortality is actually a little bit less in the group that got PPIs. I don't have an explanation. Right? There's no difference in pneumonia. There's no difference in C. diff. I don't know why these indications or signals towards mortality are there. Are there side effects of these drugs? Sure. C. diff is certainly a possibility in the outpatient world. There's lots of cohort studies. I've shown you a little bit with pneumonia. I'll show you some more, and I'll show you some more on delirium. This is the meta-analysis of sucralfate versus either PPI or H2RAs that we did, and you see that sucralfate that doesn't change gastric pH, there's an association with increased pneumonia compared to acid suppressants. Again, most of the H2 blocker studies were done at a time when we dose adjusted for gastric pH above 4. Why do I bring that up? Because there are some data out there that suggests you change the microbiome when gastric pH maintains above 4 for over a 12-hour period. H2 blockers aren't very good at doing that, so if you give intermittent, they're probably going to let the gastric pH come down. PPIs are very good at doing that. I'm going to go into a little bit of research that I've done that's looking at a mouse model, but we know that if you change the microbiome, you change the expression of certain neuromodulators, okay? Lots of different bugs produce different neuromodulators. The ones I'm going to highlight here, this is a mouse model we do where we stress them. They get ulcers that look just like stress ulcer prophylaxis. We give them a PPI, and guess what? You see the most change in microbiome. When we sacrifice the mice, we get the hippocampus, we start looking at gene expression. You see that gene expression is altered, and you start mapping these genes. You see that these genes are associated with dopamine and other signaling that is associated with delirium. Obviously, we can't test mice for delirium, but I'm speculating here that this might be one of the reasons why, if you change the microbiome, PPIs might be associated with worse outcomes. I'm not 100% sure. It's all speculation. This is our data. This is just raw data at the University of Colorado Hospital, so for a 5-year period. I don't want you focusing so much on GI bleed and mortality, but rather look at the numbers, 3,900 patients, 7 bleeds. 3,900 patients, 7 bleeds. We're giving all of our patients stress ulcer prophylaxis to prevent 7 bleeds, okay? Look at the duration, the average duration of mechanical ventilation, about 3 days. Average duration of stress ulcer prophylaxis, about 10 days. So they're getting it for 7 days past their extubation, all right? We did do multivariate regression analysis. Guess what? PPIs were associated with increased mortality. So, I'm sending a signal here, and I say that our institution is slowly adapting towards H2RAs. I'm not saying you shouldn't use PPIs. I'm saying reduce the duration. So my take-home messages, I think either are appropriate. I think there's some studies that should be done looking at PPI versus H2 blockers and looking at mortality and other complications. You'll notice our recommendations from guidelines differ. I'll argue ours is right. Nah, I'm just kidding. All right, the duration, which I know Dr. Barletta was going to talk about, but that's really where the take-home message is. I would challenge you all to go back to your ICUs and see what you're doing with stress ulcer prophylaxis. And lastly, because I was co-chair, I just want to thank those individuals that were part of this. It does take a lot of work, a lot of writing, a lot of meetings, a lot of headbutting, a lot of arguing, and ultimately a lot of beer. All right. And with that, I'd like to introduce our next speaker, Dr. Jeff Barletta. He comes to us from Phoenix. He is a professor and vice chair at Midwestern University in Phoenix, Arizona. He's also an SCCM council member, so if you have any suggestions for him, he's the person to go to. Just kidding. See if I get to you're down here, right?
Yep.
Get out of your way.
All right. Well, thanks, Rob, for the nice introduction. I was having flashbacks during your talk of cimetidine infusions and litmus paper.
I couldn't resist.
Ouch. Well, it's a pleasure to be here to talk about one of my favorite subjects in the world, probably like both of you, stress ulcer prophylaxis. So I'm going to be focusing on 5 PICO questions, and these are all shown here, but then again at the end I want to take a little bit of time just to talk about the revised study and how the data there may impact these recommendations. So let's start with routes. So here we're comparing enteral with IV routes of administration in patients who do have risk factors. So one thing throughout my talk to pay attention to is, do these patients have risk factors or do they not have risk factors? So high versus low risk. And we're going to focus on the outcome, clinically important upper GI bleeding. So when we did our literature search, we found that there were no studies that were designed to directly compare routes of administration. And furthermore, there were insufficient data to compare IV with enteral routes within each medication class. So all of these comparisons that I'm going to show you do include the residual effect of medication choice. So for example, if you have a study comparing an IV PPI with an enteral H2 blocker, you're also going to see the confounding effect of PPIs versus H2. So just keep that in mind. Here are the results from the network meta-analysis, and again, we'll focus on clinically important bleeding. And in summary, as you see, the enteral PPIs were superior to IVH2 blockers. But then again, enteral PPIs were also superior to enteral H2 blockers. So again, if we want to focus on IV versus PO, these results are largely confounded by drugs, so something to keep in mind. So with that, the committee issued a conditional recommendation. We suggest using either enteral or IV routes of administration for stress ulcer prophylaxis in high-risk patients. And this is a conditional recommendation based on very low certainty of evidence. Well, moving on to dose, so low dose versus high dose, and again, these are in patients who do have risk factors. And you know, when I talk about low dose, you can see how that's defined below, but really low dose is probably the standard doses that you're all using. But similar to the last PICO question, there were no studies designed to compare dose, and once again, all of the comparisons do include the confounding effects of medication choice. Here are the results. There really isn't much here that's noteworthy. PPI, high-dose PPIs were superior to low-dose H2RAs, but then again, low-dose PPIs were superior to low-dose H2RAs. So we really didn't see an advantage here with high-dose therapy. As you probably all would have expected, you know, you don't need pantoprazole infusions to prevent stress ulcers. So we issued a good practice statement here that low-dose stress ulcer prophylaxis should be administered in critically ill patients who are at high risk. So next is duration. How long do we need to continue stress ulcer prophylaxis? And I just want to take a minute here to explain how this was evaluated. So these are patients with risk factors who no longer have those risk factors, and we evaluated if stopping or continuing stress ulcer prophylaxis influenced outcomes. So we didn't compare, you know, 5 days versus 10 days or any exact number like, you know, we commonly see in infectious disease trials. So that's something to keep in mind. But once again, there were no studies that directly compared duration of therapy. But what we did find is a number of cohort studies that identified factors that led to continuation of stress ulcer prophylaxis or prolonged stress ulcer prophylaxis, and they're shown here. Now, this doesn't necessarily mean that outcomes are better in these populations. It simply means that, well, these were the factors that were identified as being associated with prolonged stress ulcer prophylaxis use. Now, one thing that I thought was interesting is if you go back to the most recent randomized controlled trials and the duration of therapy that was utilized in these studies, you can see that it's relatively short, right, between 3 and 5 days. And perhaps this is somewhat shorter than what we typically see in practice. If you focus on the figure at the bottom, this is the time to GI bleed, and these data come from the SUP-ICU trial. And focus your attention on the dark bar, which represents the first GI bleed. And you can see that most bleeds occur early in the ICU stay, within the first 7 days. So it really begs the question, do we need to continue stress ulcer prophylaxis far beyond that point? And certainly we'll need more data to better evaluate that question. But all in all, I think this represents, you know, the time when stress ulcers occur, when bleeds occur, and it correlates somewhat, I believe, with just the recovery of critical illness and resolution of risk factors. So here the committee issued a good practice statement that stress ulcer prophylaxis should be discontinued when the risk factor that led to its administration is no longer present. So what about enteral nutrition? This is probably one of the more common questions that I'm asked. Do we need to continue stress ulcer prophylaxis in patients who are on tube feeds? So here I'm going to focus first on patients with risk factors and again the outcome of clinically important bleeding. So we know that enteral nutrition is associated with numerous beneficial physiologic effects. In fact, prior studies have shown that enteral nutrition is protective. But keep in mind, no study has directly compared enteral nutrition with drug, where the drug group is not being fed, right? Because we can't design a study where we're going to say, we're going to give you drug, but we're not going to feed you. So that's highly unethical. So what you'll find here is that the comparison is typically enteral nutrition alone versus enteral nutrition plus drug. So here we do have some data, and you can see that the group that received enteral nutrition plus drug had a lower incidence of clinically important bleeding. That being said, there was also a higher incidence of hospital-acquired pneumonia. Now, what I find interesting in this cohort of studies, if you look at the cumulative incidence of GI bleeding, of clinically important bleeding, it's 3.5%. So that's right in the range that you commonly see quoted across all stress ulcer prophylaxis studies. So I just like to highlight here that 3.5%, well, it's not zero, right? So these patients who are on enteral nutrition, they still have the potential for GI bleeding. And as you can see here, there is some benefit with providing drug on top of that. So here we stratified our recommendation into two based on the presence or absence of risk factors. So in patients with risk factors, we suggest using stress ulcer prophylaxis in critically ill adults who are enterally fed. However, in patients who do not have risk factors, we suggest not using stress ulcer prophylaxis. All right, the last PICO was in patients who are on acid suppressive therapy medications prior to their ICU admission. So what do we do with those folks? And here, once again, we stratified this into two sub-PICOs, patients who do not have risk factors and patients who do. So no data that we can use to meta-analyze here. So we issued a good practice statement. In patients who do not have risk factors, the indications for these medications should be reviewed before we continue with therapy. We know that a number of patients in the ICU receive acid suppressive therapy, or they were on acid suppressive therapy prior to their admission without a really good indication. And unfortunately, there's a large number of patients where that indication was probably continuation of stress ulcer prophylaxis from their last admission that never got discontinued. And that's been widely published in the literature. So I think it takes a little bit of investigation as to why patients are on these medications before we just automatically push these forward. Now, in patients with risk factors, we've issued another good practice statement. The consideration to change the medication to the most preferred agent for stress ulcer prophylaxis must be weighed against the indication that required the stress ulcer prophylaxis therapy before ICU admission. So during this time, we identified a number of research gaps, and Dr. Dionne nicely explained some of these. I feel this could be a talk in itself. Really what I want to focus on is the REVISE trial and how does this impact the recommendations that we presented. So, REVISE was an amazing study comparing pantoprazole with placebo. You've seen the results, a reduction in clinically important bleeding, along with patient-important bleeding, and then no real difference in any of the other secondary outcomes. So let's go back to the guidelines and the recommendations in the guidelines, and we'll compare and contrast the recommendation with the data from REVISE. So we'll start with risk factors where, again, coagulopathy, shock, and chronic liver disease were considered risk factors. Note the absence of mechanical ventilation. But you might say, well, REVISE was conducted in patients who were mechanically ventilated. So I think, you can make the argument that we should be using stress ulcer prophylaxis in the population that was studied that showed its benefit. I think that's a valid point. I agree with that. But I think you have to look a little bit deeper with REVISE besides the fact that these patients were mechanically ventilated. 70% of patients were on an inotrope or a vasopressor. About 6% required renal replacement therapy. So these weren't just patients who were mechanically ventilated without other risk factors. Now, if we combine REVISE with SUP ICU, recognizing that these two studies represent about 90%, 91% of all the patient data in randomized controlled trials for stress ulcer prophylaxis, you can see once again that these patients had a multitude of risk factors. So I tend to think that perhaps we have to look at mechanical ventilation a little differently. And I like to think of the patient that is on 100% FiO2, on APRV, on neuromuscular blockers for ARDS, right? And then I think of a second patient who's mechanically ventilated because they were combative in the emergency department and they had to be intubated to facilitate a physical exam. So two very, very different patients, but they're both mechanically ventilated. So do I think tomorrow you should go and discontinue stress ulcer prophylaxis on all your mechanically ventilated patients? Well, no. But do I think it should be an automatic checkbox on an order set that every patient who's mechanically ventilated receives it? Well, no, that's not appropriate either. And I think this does require a little bit of a deeper dive and an evaluation of these patients. How are we defining critical illness? What are the other risk factors? You know, what is their trajectory? Are they getting better or are they getting worse? And we truly have to take that individualized approach, which is probably a little bit different than what we've been doing over the past, I don't know, 20, 30 years. Do we need stress ulcer prophylaxis? Well, you know, this is an easy one. Again, with REVISE, we saw the benefit in clinically important bleeding, and then that was confirmed with the systematic review. Same data that Rob and Joe presented. Stress ulcer prophylaxis medication, you know, where we suggested either or. Again, these data were presented earlier. I think, you know, the discussion that we had on the committee, you know, when Rob presented the case and you all raised your hand, who would use a PPI, who would use an H2RA, it was probably about an even split in the room. You know, we probably had an even split on the panel, too, with what we thought the preferred agent should be. But again, highlighting the possibility of mortality in the more severely ill, critically ill patients, and the fact that you can't really rule out the increase in mortality with PPIs. So, you know, again, here, I think we need to take an individualized approach, choose the right drug for the right patient. With enteral nutrition, where we recommend or we suggest stress ulcer prophylaxis in critically ill adults who are enterally fed, well, when you look at REVISE, 92% of those patients were on enteral nutrition, and there was still a benefit that was recognized with clinically important bleeding. So with that, once again, I want to acknowledge the other authors on this paper. I often say critical care is a team sport. Well, so is making guidelines. So thanks for your attendance, and thanks for your time.